So our closing remarks are going to be by Dr. Tom Shanley. He's probably one of the brightest people I have had the privilege to know and to work with. And so please join me in welcoming Tom Shanley.
So thanks very much. That's very kind, Marita. And I have a terrifically intelligent team that enables our institute to do many of the great service things that we hope to do on behalf of our investigators. And I'm also keenly aware that I think I stand between you and one of the beautiful Michigan sunshine days, so I'll try to move this forward quickly. This is actually it's a slide that that's probably been refined several times, but originally I grabbed from Marita when we started working together a couple years ago. And it really describes, for me, the mechanisms of what we're talking about in terms of discovery science being translated from the bench into clinical efficacy, proven clinical efficacy, expanded into effectiveness, and identifying a best practice that then needs to be disseminated into the population to improve and impact the health of that group. And I always put it on here, there's several things there. One is the arrows that connect this can certainly be bidirectional. They sort of go in an iterative directional cycle. But there are maps and routes on at each of these stages. So wherever you are in discovery science to impact health, you can route yourself onto this process and become engaged with many multidisciplinary people that work at different places on that spectrum of translation that we talk about. And so, I think it's critical in terms of beginning to move things forward that we've heard this concept of team science and collaborations, and one of the things that I think we take most seriously as our mission within MISHAR is the role of both educating as well as collaborating around these various domains that will advance our impact of our discoveries. I am going to fully disclose that I live a little bit earlier on the translational spectrum. I have a bench lab over in BSRB. I do translational work in the intensive care unit and part of a clinical research network that does interventional trials in the ICUs. So I span a broad spectrum of things, but I really don't span out into implementation. But I think anyone that's involved in health care and has a goal in improving health outcomes, you are a consumer, I would say, of implementation science. This is some of the examples of where I have to experience this and therefore appreciate the need for us driving the science forward from the standpoint of impacting health. So Kato Han, Yong Han is a member of our division who published this work in looking at fluid resuscitation for children that were out in the community in shock. And that if you actually developed a pathway, developed some guidelines, and in fact implemented them, you could see that you could improve health outcomes. So if you look at the y-axis of patient survival, these are young children who typically have severe infections and septic shock. If you're able to utilize an algorithm and reverse their shock, they do significantly better than those that have persistent shock. And we've tried to make some guidelines, some algorithms to direct clinicians in terms of how to provide this resuscitation. These are the American College of Critical Care Medicine and Pediatric Advanced Life Support guidelines. If you follow those, you can see that there's a significant difference in terms of improved outcomes from that aspect. So the key is how do we get all 64 of the sites, or all 64 of the 91 sites, to actually follow the algorithms more effectively, and in this case, in an out-of-hospital setting in terms of resuscitation. We've heard this as well today in terms of the variability amongst practice. So what you're seeing here on the y-axis is sort of the incidence of bloodstream infections. And as you see the letters running across the x-axis, those are the individual units. So you can see tremendous variability. And how do we take advantage of the science that can allow us to look at, for example, Unit G, who's before any implementation of any algorithms or protocols, discovered some way to do things quite well, as opposed to someplace like I, which is clearly not having the kinds of outcomes that we would want. And so this really led, and Dr. Clancy referred to the adult component of this in terms of the Keystone Collaborative, but we participated in a NACRI, now the Children's Health Association, a NACRI collaborative to borrow a protocol, an algorithm on how to insert and manage central lines in children. And you can see over time the impact that this can have on a single unit. And to be honest with you, I understand the complexity of doing this. I was directing the intensive care unit when we rolled this out, and it's much, much more difficult than just getting a hold of an algorithm and a protocol and a guideline. There was significant amount of culture change and work that went through the process to even begin to accept this, particularly among senior clinicians like myself who always know how to do things right, regardless of what you tell me to do. Right? So there is that concept of senior people having to evolve in terms of their approach and understanding that things can change. When you scale this up, the power of implementation, of being able to scale this up across 40 centers, you can see the enormous impact at a national level that you can have. So you see the drop in the red bar, the red line demonstrating this prospectively defined infections dropping to a third of what they started. And what you can see in terms of the infections prevented in terms of the light blue bar, and even an estimate, a point estimate of the deaths that would then be prevented based on historical data associating bloodstream infections with mortality in the intensive care units. So this is the kinds of impact. And by the way, this isn't a randomized control trial, right? So I'm not entirely sure what the gold standard of knowledge synthesis needs to be to improve outcomes. And I think that's part of what we've heard today as well. We talked about cost, so I threw this up. Who is responsible? I can tell you that in the intensive care unit, the Division of Critical Care Medicine in the Department of Pediatrics paid for all this initiative. But we saved the hospital a lot of money. Should there be some contribution of hospital resources to be able to implement these kinds of work? And so the discussion that we heard, I think, is a very important one. I will say, I think Jack left. Is Jack still here? And this is not a criticism of anybody who I may not know in the room, but Jack is probably the highest administrative person who was at the conference today in the health system. Where are they? So it would be important to partner, I think, between the health system and the changes that we can potentially implement that would have impact on what we do as that health system. So opportunities. Now, I'll also get a little bit personal in terms of how this can impact and what we need to do, and tell you about a case we took care of in the intensive care unit about 2 weeks ago. So a 12-week-old female came into the emergency department with a cough and with increased work of breathing. This is actually directly from our EHR admission note on this young lady. Born at 39 weeks gestation via an uncomplicated repeat C-section. She had had 2 prior emergency department visits when she was younger for what was described, and I don't actually know if it was proven as RSV bronchiolitis, but has been well otherwise. And interestingly, she's not up to date on her immunizations. And that was an intentional parental decision. So I'm not going to make judgment calls about decisions around vaccines, but there could be no greater challenge in terms of implementation science, messaging, marketing, et cetera, that can have tremendous impact than in terms of vaccine biology. Unfortunately, this young lady was noted to be tachypnic, had increased work of breathing, her vital signs, she was febrile, very tachycardic, tachypnic. The saturation, the SpO2, for those of you that are non-clinicians, that's a low oxygen saturation. It should be 100%, is 83%. And remarkably, on her laboratory, her white blood cell count, which is normally around 6 or 10, was 54,000 as opposed to 10,000. Over the days that she was with us, her white count grew to 45,000, 51,000, 63,000, 89,000. I know you're thinking that she has leukemia. In fact, she doesn't. What she has is a vaccine-preventable illness called pertussis. And in fact, this young lady succumbed to her pertussis after about 7 days in our intensive care unit, most likely from an acute pulmonary hypertensive crisis related to her leukocytosis. So what do we as a community know about leukocytosis and critical pertussis? Well, there is some evidence, and maybe it's not perfect evidence, that if you could rapidly leukodeplete children that have very high white blood cell counts from pertussis, you may be able to improve their outcome. If you look at, this is a summary of the pediatric paper there, what this study adds is that treatments aimed at reducing very high white blood cell counts rapidly in severe infantile pertussis seem to improve survival as compared, now not a randomized controlled trial, but as compared to historical controls. We were unable to leukapheresis this young lady because there was insufficient evidence in the minds of the team that does the leukapheresis for us as a health system. So it's really this concept between, we were talking about practice-based decisions versus on-the-spot decisions, and how it can affect implementation, and how it can personally really at times affect outcomes, perhaps, right? So I don't want to leave you on that down note, though, because I included that because it was such that tension that Dr. Grimshaw brought out for us, is part of this whole process that I think we need to consider, and very complex. And even the concept around an unvaccinated child based on a parental decision, and the complexity around that aspect of it. So I appreciated the panel sharing. I thought that was a very good charge that Lee did to them, is what are the priorities. And I actually would say these resonate very highly with me, and the highlights are my own, and I tried to type fast as they were commenting on those. But I do think content expertise, both in terms of the scientific reviews that we will anticipate being the judges of the the people that will be doing the education of the grant applications themselves, as well as the publications and reviewing publications, that we really need to both have those people at the table, and what is implicit to me but not explicitly stated there is making sure that we're continuing to develop our pipeline of implementation scientists and the training opportunities that we have. A lot of young people in this audience, and that's very exciting to us to see that. I think this concept of partnering or collaborating with people who really want to improve care, and I think this concept is something that strikes home to me because, as I said in the question, we see so many studies where so much of our patient cohort that typically would be looked at in terms of the intervention, it has to get perfect. You take all the confounders out until you get to a very small population to have that very clean randomized controlled trial. And then when you try to scale that back up into our large populations, we lose the effectiveness. So is that really the right approach, or do we need to have better study designs in the real world environments? I would even say, and people who know me and have worked with me a while know, make me king for one day, and that will be what we do, is we will have one single information system for healthcare in this country. But at least a step for the investigators could start by having common language, common measures and languages and taxonomy. And we even heard that from ARC, from Dr. Clancy, that really needs to be one thing that can really allow us to move the field forward, because we can move from centers to networks to countries to international work and really move things forward. Until we have that capacity, we are having a huge missed opportunity in collaborations. And then finally, considering the cost of implementations. And I do hesitate to say that I have been impressed with how often people have come up with the implementation and the intervention ignorant of the cost, but then looked at the impact in terms of the cost savings versus the cost of implementing it. And it almost always, and I'd be happy to hear examples where that's not the case, almost always pays off. So I think if we put, and maybe this is a little bit too much idealism, if we put patients first and drive for the best outcomes first and worry about cost second, we may actually see that that's the best approach anyway in terms of the cost savings that we will have. So at the beginning of the day, those are my closing remarks. Marita gave her opening remarks in terms of outlining the need for implementation science as a part of CTSA. I'm very delighted to that MISHAR is able to sponsor this inaugural event led by Marita, and I congratulate her personally and the organizing team that worked to bring a terrific team of speakers to the session, and many positive comments throughout the day. So I think this is a great first step in terms of our implementation science as part of the CTSA. And MISHAR takes that mission very seriously in housing our CTSA here, and will continue to try to provide leadership and drive towards new initiatives and provide support, as Marita mentioned, with pilots coming out, new pilot initiatives in implementation science, and certainly a commitment to all of you young people to train the next generation of implementation sciences as we move forward from that aspect. So without any further ado, I will thank you for your presence today and your participation in this terrific conference. I think it was Lao Tzu that said, the journey of 1,000 miles starts with the first step. Actually, I believe he said it starts under your feet. was the original translation, which meant you sort of had to pause and think about where you were before you started your journey. And maybe this is that opportunity to sort of pause and see where we are and now develop sort of our next steps. And I look forward to having you all participate in where we move forward.